So let's go to the doses. Suppose a patient has opportunistic infection, that is pneumocystis carinii pneumonia. Usually threshold says that if it is below 200, you should give trimethoprim sulfamethoxazole, that is one double strength daily. If patient does not tolerate that, you can give one single strength as well. This has to be given daily. Patient can take. If it patient is not tolerant to that, you can either use Dapsone or Atovac-1. And when you can stop it, suppose a patient on ART is there now from 200. Now, if it has improved to more than 200, you can actually start on ART. That is, patient on ART getting more than 200 now. If it is staying that for more than 3 months, that means you have repeated one CD4, now it is 200. Now after 3 months, again you do CD4 count is again more than 200. You can stop this therapy. That is trimethoprim sulfamethoxazole therapy can be stopped at this stage. Similarly, toxoplasmosis, here the threshold says that less than 100 you should start. And similarly, if the CD4 count is more than 100, that is 200 for more than 3 months, you can stop the therapy. And the drug is the same for both of them. Mycobacterium avium complex is usually the prophylactic therapy is required if the CD4 count is below 50 and the drug is azithromycin. You can give 1200 mg once weekly or clarithromycin 500 mg twice daily. So either of these two therapies can be used. Other drugs is rifabutin. And usually this can be stopped if the patient has a CD4 count of more than 100 for more than 3 months. Suppose patient has started on ART therapy and on ART therapy patient has improved. CD4 count has improved from less than 50 to more than 100 and should maintain for at least 3 months. For tuberculosis, that means the latent tuberculosis, if you detect a positive TB test, which is either can be a skin test or you can have a IGRA test. If positive TB test for this patient, you have to give isoniazid 300 mg daily plus paradoxine you will give for 9 months. This is for latent tuberculosis. Other alternatives is rifampicin 400 mg daily for 600 mg daily for 4 months. So for cryptococcal meningitis, usually no routine recommended therapy is there, but usually if you want to give, you can give if the CD4 count is less than 100. The drug of choice is fluconazole 200 mg daily can be given only for high risk patient, not routinely recommended here. And if the CD4 count is more than 100, you can stop that. So again, the prophylactic drugs are available only for the PCP, toxoplasmosis, which is trimethoprim sulfamethoxazole, Mycobacterium avium complex, latent tuberculosis, and cryptococcal meningitis. Thank you.